Hello, my name is Philip George, and I wanted to thank SAGES for the opportunity to present. My talk is entitled Impact of Body Mass Index on Perioperative Outcomes Following Minimally Invasive Retromuscular Abdominal Wall Reconstruction, a Comparative Analysis. I have no disclosures. Incisional hernias are one of the most common diagnoses a general surgeon sees in practice. When there are about 350,000 laparotomies performed in the United States annually, with an incisional hernia rate as high as 20%, it's not a surprise to see this pathology often. With obesity rates as high as 42%, the treatment of hernia disease is becoming more complex. In patients with higher BMI, traditional hernia repairs can be quite complex, especially considering the technical aspects of excess adipose tissue. Some patients would not be deemed candidates for hernia repair unless they were able to lose weight. With traditional approaches, the surgeon takes on excess risk with higher BMI patients, which may outweigh any immediate benefit of an elective procedure. However, these higher BMI patients are at higher risk of incarceration and strangulation, along with the complications that arise, such as bowel ischemia and perforation. Advancements in minimally invasive abdominal wall reconstruction have allowed practices to extend hernia treatment options to higher BMI patients who are symptomatic from the hernia but unable to lose weight. Retrorectus dissection and transversus abdominis release are now being commonly done through either robotic or laparoscopic approaches, and these can potentially lead to improved perioperative outcomes. However, these outcomes have not been widely studied. The purpose of this study is to evaluate the effect of increased BMI on perioperative outcomes during minimally invasive hernia repair. At our institution, we reviewed all patients who underwent minimally invasive abdominal wall reconstruction using transversus abdominis release or Reeve-Stopa techniques between September of 2015 and April of 2019. We excluded patients getting paniculectomies and those with ostomies. We then separated patients by BMI into higher BMI and lower BMI groups using 35 as our cutoff. Our primary outcomes were recurrence of hernias, length of stay, and surgical complications such as infection, seroma, and hematoma. Our secondary outcomes included ileus, bowel obstruction, UTI, thromboembolic events, or cardiac, respiratory, or renal complications. Our statistical analyses were performed using the following tests. Our patient demographics showed that the average BMI was 29 in the lower BMI group and 41 in the higher BMI group, with a higher likelihood of hypertension, diabetes, and higher ASA status in the higher BMI group. Higher BMI patients were also likely to have a recurrent hernia and were more likely to have their surgeries performed robotically. In terms of operative statistics, higher BMI patients had a significantly longer operating time, as well as larger implanted mesh. Length of stay, percent and length of drain placements, and hospital costs were similar between groups. In regard to perioperative complications, there was no statistically significant difference between the groups, with a similar follow-up time of around 7 months. When you extend the data only to those who had a more than 12-month follow-up, there was still no significant difference in perioperative complications between either group, with average follow-up time of around 18 months. There was only one recurrence, and this was in the higher BMI group. This study shows that perioperative outcomes are equivalent between high and low BMI groups when undergoing minimally invasive abdominal wall reconstruction at our institution. These outcomes continue past the 12-month follow-up. However, further studies are needed to fully elucidate these findings. Some limitations of our study is that it was a single institution study and that it was retrospective in nature. Again, I thank you for your attention and to SAGES for this opportunity.